All right, welcome to the Auditory Learner. This is going to be part 2 of the Perio Final Study Guide. So let's jump right into it. So just to simplify the concepts to review first, when we're calculating cal, if we're doing calculations with pocket depth and regular recession going apically from the CEJ, the recession, then we're going to be adding it. And if we're going the opposite direction, if we're going coronally from the CEJ, then we're subtracting pocket depth with the measurement above the CEJ. Also, mobility plus is barely discernible. 1 is 1 millimeter movement, 2 is greater than 1 millimeter movement, and 3, it is depressible. Also, let's talk about perio staging and grading. So the key things for stage 1 is 1 to 2 millimeters interdental cal, no tooth loss, and maximum probing depth is less than or equal to 4 millimeters for stage 1. For stage 2, it is a 3 to 4 millimeter interdental cal with 15 to 33% radiographic bone loss, no tooth loss still, and the maximum probing depth is less than or equal to 5 millimeters for stage 2. For stage 3, it's 5 millimeters or greater interdental cal. Here we have 4 or less teeth missing, and the periodontal pocket depths are 6 millimeters or greater. And you also may have class 2 or 3 bifurcations. And stage 4 is going to also have a 5 millimeter or greater interdental cal. However, here we have 5 or more teeth missing, and less than 20 teeth remain. And you have a tooth mobility of 2 or 3, along with secondary occlusal trauma. So real quick, stage 1, 1 to 2 millimeters interdental cal, maximum probing depth is less than or equal to 4. Stage 2, so that was stage 1. Stage 2 is 3 to 4 millimeters interdental cal, no tooth loss. Maximum probing depth is less than or equal to 5 millimeters. Stage 3 is 5 millimeter or greater interdental cal, and you have 4 or less teeth missing, and pocket depth are 6 millimeters or greater with class 2 or class 3 bifurcations. And stage 4, also 5 millimeter greater interdental cal, you have 5 or more teeth missing, or less than 20 teeth remain, and tooth mobility of 2 or 3 with secondary occlusal trauma and bite dysfunction. Great. Now, grade A is slow, meaning that there's no radiographic bone loss or cal over 5 years, and people don't smoke and they don't have diabetes. Grade B is moderate, which is where we start when we're grading and staging. It's less than 2 millimeters of radiographic bone loss or cal over 5 years. And the modifiers for that is that they smoke less than 10 cigarettes and have an HbA1c of less than 7. Grade C is rapid, and that's 2 millimeters or greater radiographic bone loss or cal. And it is destructive, and people here smoke 10 or more cigarettes and have a higher HbA1c of 7. So this is very, very important to understand. Let's see if I can simplify it even further. Stage 1, 1 to 2 millimeters interdental cal. Maximum probing depth is less than or equal to 4. Stage 2 is 3 to 4 millimeters interdental cal. Maximum probing depth less than or equal to 5 millimeters. Stage 3, 5 millimeter or greater interdental cal. Pocket depths are 6 millimeters or greater. Stage 4 is 5 or more teeth are missing, or less than 20 teeth remain, and tooth mobility of 2 or 3 with secondary occlusal trauma and bite dysfunction. All right, so know that. Grade A, slow. Grade B, moderate. Grade C, rapid. Grade C, 10 or more cigarettes per day with an HbA1c of greater than 7. Grade B, less than 10 cigarettes per day with an HbA1c of less than 7. Grade A, slow, no smoking, no diabetes, and no cal or bone loss over 5 years. The next thing that I want to go over real quick is occlusally related vocabulary. So primary occlusal trauma is excessive occlusal forces placed on normal periodontium. Secondary occlusal trauma is excessive occlusal forces on already affected, periodontally affected periodontium. Extrascapular means muscles, and it is TMD related. Intrascapular is joint, is also TMD related. Macro trauma is one event. Micro trauma is many small events. Four signs of symptoms of temporomandibular disorders: pain and tenderness in muscle, pain and tenderness in TMJ, pain and clicking when clicking or popping of the joint, and limited mandible movements, limitation of the mandible. Those are the four signs and symptoms of TMD. Let's go to the systemic factors. So systemic diseases and factors that are bidirectional are, we have smoking, diabetes, metabolic syndrome, leukemia, HIV, AIDS, stress, neutropenia, Down syndrome, and medication side effects. Let's start with smoking. Smoking increases the risk for attachment loss. Smoking is a vasoconstrictor, increases interleukin 6, decreases osteoblasts, decreases neutrophils, decreases fibroblasts, decreases collagen. 50% of periodontal cases are people who smoke, and heavy cigarette use is greater than 10 cigarettes per day. Now, the impact on smoking is BIB, biofilm, immune system, bone. Now, diabetes. Type 2 is more prevalent than type 1. We already know what those are. Diabetes causes delayed healing. It causes hyperinflammatory response to oral biofilm. You are 3 times more likely to develop periodontitis if you have diabetes, and then 20 times more likely if you smoke and have diabetes. Diabetes also causes impaired chemotaxis. It's pro-inflammatory cytokines also, and it causes defective neutrophil function, just like smoking. Metabolic syndrome is obesity and diabetes. What we need to know about this is that everything increases with obesity, not just your weight. So you have increase in adipocytes, adipokines, inflammation, insulin resistance, and gum disease. Now let's talk about leukemia. Leukemia is cancer of the blood cells. What happens with that? You get oral mucositis, sloughing of the mucosa, xerostomia, and candidiasis. HIV, you get hairy leukoplakia, Kaposi sarcoma, candidiasis, and LGE, which is linear gingival erythema, which is 2 to 3 millimeters of marginal band of intense free gingiva, does not affect cal or bone levels. I repeat, does not affect cal or bone levels. And it is treated with standard therapy and chlorhexidine. Now, stress is cortisol and hormones. So let's talk about that. Acute stress is good for you. Chronic stress is bad. Pubertal gingivitis occurs equally in males and females. Second and third trimester gingival inflammation with P. intermedia bacteria increases with estrogen. You can have low birth weight baby if periodontitis persists and enters the bloodstream. Also, cancer and osteoporosis treatment can cause osteonecrosis of the jaw because of the bisphosphonates. And I'm including that in there because it's talking about hormones and pregnancy. And osteoporosis is related to women. Also, pyogenic granuloma is not cancer. Now, neutropenia is a low white blood cell count. If it's less than 1,500 cells per liter of blood, neutropenia is considered immunocompromised, and neutropenia is also the polymorphonuclear PMNs are the first responders. We know what Down syndrome is, trisomy 21. Let's talk about medication side effects, xerostomia and gingival overgrowth. Gingival overgrowth, there's 20 meds. The 3 main ones that cause gingival overgrowth are anticonvulsants, phenytoin, dilantin, immunosuppressives such as cyclosporins, and calcium channel blockers that end in the with the word dipine, pine, nifedipine, imladopine, things like that. So let's get to some other things that we need to understand here. Things that are important. Let's see. One of the things that I typed here is that we need to understand not just the red complex, not just the red complex bacteria, which is please go take Freddie to dinner, but we also need to know that when it comes to the red complex bacteria, that there are 3 virulence factors, which are proximity to tissues, ability to evade host, and ability to destroy tissues. Great. Good. So we went over all that. Let's see what's next. Great. Also, let's review the dental hygiene treatment planning. There are one, two, three, four, technically five because it starts at zero. So zero is the emergency phase. Stage zero is emergency phase. Stage one is the hygiene and oral hygiene and the cleaning phase, which is the R phase. Stage two is the perio or the oral surgery phase. After the cleaning, if they need anything extracted or they need gum grafts or bone grafts or whatever. Stage three is restoration or orthodontics. Again, we're not involved in stage two or three. Stage uh, Again, stage three would be if they need a full mouth reconstruction or any crowns or fillings. Stage four, here we come back, which is where we maintain the patient's periodontal health. Patients should stay here, and this is where we might do selective SRPs at sites that are 5 millimeters or greater with BOP. Um, Again, so there's stage 0, 1, 2, 3, 4. Hygienists are involved only in stage 1 and 4. Stage 0 is the emergency phase. Stage 2 is the periodontal oral surgery stage. Stage 3 is the dentist phase. And we are 1 and 4. So most patients stay at 2, 3, or 4 every 3 months. Um, also, the three goals for treatment planning are EMP: eliminate, maintain, and prevent. And again, we talked about it when we're doing the staging and grading. Cal is the best indicator for perio disease. We need to make sure that it's generalized. If it is 30% or greater, it's local. If it's less than 30%, and only consider subgingival calculus. Start with the worst quad if patient is on time, or easier quad if the patient is late. Also, we have the prognoses, which is excellent, good, fair, poor, or questionable. Excellent is excellent, good is adequate, no frications. Fair is 20 to 40% bone loss with class 1 frications. Poor is 40 to 50% bone loss with class 1 or 2 frications. Questionable is class 2 or 3 frications with advanced bone loss. And then we have uh, hopeless, which is terminal. Class 3 mobilities, uncontrolled, pretty much no hope. So just to review all that, there's 6 prognoses: excellent, good, fair, poor, questionable, hopeless. The ones we need to make sure we know of is the third and the fourth one. That's where we decide whether the patient's going to keep their teeth or not, because if it's fair, there's a chance that they can go back up to excellent. But if once they hit poor, things are like a landslide. So fair, again, is 20 to 40% attachment loss. Poor is 40 to 50% attachment loss. Then it goes to questionable, then hopeless. So excellent, good, fair, poor, questionable, hopeless. 6. Um, so that's really quick with the dental hygiene treatment plan. Eliminate, maintain, and prevent is our goal. And also, we need to understand what is ADPI as well. ADPI is the not the goals of the treatment plan, but that's the dental hygiene process of care. That's going to be assessment, diagnosis, planning, implementation, and evaluation. ADPI: assessment, diagnosis, planning, implementation, and evaluation. Perfect. So we got that. Now we're going to review the gingival curettage real quick as well. Gingival curettage. It is scraping or cleaning of the walls of the cavity or surface by means of a curette to remove disease and soft tissue within the pocket wall and the junctional epithelium. It's done on granular tissue with chronic inflammation, which is blue or purplish. So we do it anyways because it happens inadvertently when we are removing tissue. The rationale has been questioned for many years, but it is no longer considered a standard treatment because according to the AAP, there's little therapeutic value and is no longer listed as a method for treatment, but it is still part of our scope. Now, the rationale is different than the indications. The rationale is to remove granulation tissue and chronically inflamed granulation tissue, possibly containing dislodged pieces of calculus. The indication, though, are not to remove granulation tissue. The indications are for new attachment in moderately deep infrabrony pockets, or for reduced gingival inflammation when surgery is contraindicated. So if they have uncontrolled diabetes or uncontrolled hypertension, or they have systemic conditions that they may not be able to get periodontal surgery, or at recare appointments as part of their maintenance treatment. So at recurrent areas of inflammation, or when we do selective SRP, which could be part of the perio maintenance, which we talked about earlier on stage 4 of the phases of treatment. So know those 3 indications: new attachment in moderately infrabony pockets, moderately deep infrabony pockets, to reduce gingival inflammation when surgery is contraindicated for special patients, and at recare appointments if there are selective sites that need to be touched up more. Um, we're going to be using horizontal strokes, and of course, we're going to have to anesthetize. We usually use a Gracie 7-8 or 11-12 or 13-14. And so we got to use a cotton swab. And just also remember about repair. It's repair, it's not regeneration. Regeneration means it's back to how it used to be before any problems were there. Repair is just a pocket reduction and repairing the long junctional epithelium. Contraindications to gingival curettage: if we have an acute infection, if we have gingival hyperplasia from medication induced, if we have a frenum in the way, and if we have mucogingival involvement. Again, this is not a surgical procedure, but when you contraindications are acute infection, gingival hyperplasia, frenum pull on the gingival margin, and mucogingival involvement. Awesome. So we got that. Going back to periodontal, now we're going to talk about abscesses real quick. So there's periodontal abscesses, gingival abscesses, and periapical abscesses. Periodontal affects periodontium. Gingival is a gingiva. Periapical is like pulp necrosis or decay. Each type may have acute or chronic, fast or slow. So let's start with the periodontal abscess. We have the acute periodontal abscess, which is the painful one. This is the one where drainage is through the path of less resistance. Um, no, no, scratch that. Acute periodontal abscesses are painful forms when there's a pocket that becomes occluded. Okay, and then so again, acute is pain. Abscesses are painful, swelling. Um, it's a contraindication to gingival curettage, and it's also a contraindication to LDAs. Um, now, the way that we treat it is we drain it, and then so we have to obviously create some point of drainage and then treat with antibiotics or antimicrobial agents. Follow up is salt rinse. Okay, now chronic periodontal abscesses are painless. Okay, they resemble acute, but they're painless because they are already draining somewhere, either into the sinus or through the periodontal ligaments or somewhere else. So acute pain, chronic painless because it's draining. You can have a methodification. Treatment is similar to that of acute periodontal abscesses. You got to scale and plane the area. You might have to do some curettage. You definitely need local antimicrobial therapy to be administered. Patient is scheduled for follow-up and evaluate for further periodontal treatment. Gingival abscesses are the easiest. They're not perio involved. They often occur in disease-free areas. Something may be stuck there. So again, gingival abscess occur in disease-free areas. Okay, there's not much bone loss there. Okay, we still have to drain it. We may have to irrigate it, and we still possibility of SRP. Then there's endodontic abscess, which could be an infection through a cavity, traumatic tooth injury, or trauma from a dental procedure, or a pulpal infection, which can spread to the pulp from the adjacent infected tooth through a lateral canal. So you have all those. And then also understand that there can be a combination of abscesses, and then understand the difference between periocoronitis and operculum. Periocoronitis is an abscess that's associated with partially fully erupted teeth, usually the third molars, and the operculum is the tissue that goes over that tooth. So that's that. Also understand necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. So differences between nug and nup is nug is you are not losing bone, nup you are losing bone, but they're both equally painful. So recurrent nug can result in attachment loss, which then turns into nup. And for that, you also nug is not communicable, um, which is interesting. I would think that's nasty. There's no way. Moving forward, treatment again, we need to eliminate the acute inflammation, um, and we definitely need to prescribe 'em antibiotics. Um, yeah, the use of ultrasonic and topical local anesthetics may be helpful for that. And then gingival stomatitis, we're not going to get into that. Primary herpetic gingival stomatitis looks like uh, gingival erythema, but it's bigger. Um, so then also know what herpetic whitlow that can happen to a hygienist on their finger by working on people who have herpes. So there we go. Um, we got that out the way. Something else we need to get out of the way here is that one of the questions I asked him during the Zoom meeting is that diabetes, you know, what is a factor about diabetes? I forgot what it was, but he says that diabetes has a hyperinflammatory response which inhibits healing. That was the answer. Also, cal is the CEJ to the base of pocket, basically, but I prefer to think of it as either you're adding if it's a recession uh, apically, or subtracting if it's recession coronally above the CEJ. Um, so that's that. Let's see what else we need to talk about. Surgical pocket elimination. One of the last things that we need to understand here is that the angular defects, there's A, B, and C. There's three different types of angular defects. The best outcome is the one that has a three-box wall. The medium outcome is a two-box wall, and the worst outcome has a one-box wall. You can see it on the X-ray. So basically, the best outcome, if there's a hole, little tiny hole in between a tooth that you can fill. Um, B would be there's a hole, but there's also a window. And C, there's two windows, including the roof. It's gone. So the less things that are gone, the better. That's angular defects. We need to understand the difference between regeneration and repair. Um, we did talk about that a little bit. So, for example, something that we must know, periodontal surgery contraindications. So most contraindications for perio surgery are relative, meaning that we can correct it. That that may make surgery, relative contraindications are conditions that may make surgery inadvisable for some patients, but we need to see what those are. So relative contraindication of surgery are patients who have certain systemic diseases or totally non-compliant with self-care. They have a high risk of caries or have unrealistic expectations or outcomes for the surgery. Um, so some of the systemic diseases would be a history of heart attack, uncontrolled hypertension, diabetes, dialysis, HIV infection, things like that. Um, Also, if they're non-compliance with their self-care, and also if they have a high risk of caries, and also if they have unrealistic expectations, because we all know that periodontal surgery is hard to get perfectly, especially if they're doing like gum grafts and bone grafts and things like that. Um, so what else? What else? During the surgery, it's common for the gingival margin to be positioned against the teeth in a more apical position. Okay, temporarily. Let's see what else we got here. Um, let's go to some important stuff. Complications for smoking. Surgical patients should never smoke during the healing phase. Um, when we resume the routine patient self-care techniques, follow-up routine, the flap surgery of gingivectomy patient usually can resume uh, in 10 to 14 days. Patients should not resume self-care for up to 4 to 6 days. So after the surgery, 4 to 6 days, you're not doing what you're used to doing. But after 10 to 14 days, then you can kind of go back to doing your regular stuff. Periodontal dressing, that's great. We know about that. Angular defects, we know about that. So any other really important things here? Um, Great. So that's good. So one more time, I'm also just going to review everything that we kind of went over, because we got to be experts at this. So calculating cal with marginal gingiva recession that is apical. We are adding with the pocket depth, and if it's above coronally, above the CEJ, or if it's going coronal, then we are subtracting the periodontal pocket with the amount that it's above the CEJ. Percations class 1, 2, 3, 4. Class 4 is the only one that's clinically visible that you don't have to go anywhere and see it. So if it's 4, it's there, you can see it. Class 3 is there's a radiographic lucency that's for sure noticeable. Class 2, it's not that noticeable radiographically, but there you could go in with the neighbor's probe 1 millimeter or more. And class 1, you can enter the percation at 1 millimeter. Mobility plus 1, 2, 3. Plus barely discernible, 1 millimeter movement, 2 greater than 1 millimeter movement, 3 is depressible, and buccal lingual movements. Periodontal probe UNC is all the little lines, Marquise is 369. Uh, let's review the staging and grading one more time. Stage 1 is 1 to 2 interdental cal. Probing depth is less than or equal to 4. Stage 2, 3 to 4 millimeters interdental cal. Maximum probing depth is less than or equal to 5 millimeters. Stage 3 is 5 millimeters or greater intradental cal, and the periodontal pockets are 6 millimeters or greater. So one thing that I've noticed here, once we hit stage 3, 6 millimeter, the pockets are greater. Pocket depths are at 1 point or greater. Unlike stage 1 and 2, it's 4 millimeters or less, or 5 millimeters or less. Stage 3, 6 millimeters or more. Stage 4, which is the worst one, also 5 millimeters, 6 millimeters or greater. But stage 4, you have tooth mobility 2 and 3. It's depressible. It's moving more than 1 millimeter. And there's also 5 or more teeth missing, or less than 20 teeth remain for stage 4. The similarities for stage 3 and 4 is that they both have 5 millimeters of or greater of interdental cal, and that the bone loss for those two, stage 3 and 4, extends to the middle third of the root or beyond. Stage 3 and 4 are also the ones that have vertical bone loss. Stage 1 and 2 are all horizontal bone loss. Okay, so let's remember that. Okay, stage 4, again, complex rehab, secondary occlusal trauma, which involves drifting, and then grade A, B, and C. Grade A, slow, grade B, moderate, grade C, rapid. Grade C, more than 10 cigarettes per day, higher than 7% HbA1c. That's grade C. Grade B is less than 10 cigarettes per day, less than 7% HbA1c. Grade A, no smoking, no diabetes. And there is no radiographic bone loss or cal over 5 years for grade A. There's less than 2 millimeters of radiographic bone loss or cal over 5 years for grade A. And there's 2 millimeters or greater radiographic bone loss or cal for grade C. Again, primary occlusal trauma, excessive occlusal forces placed on normal periodontium, excessive occlusal forces already affected. Know the systemic factors. Okay. Perfect. Perfect, perfect, perfect. I think that's okay for now. Anything else, I will revisit. Perfect.